Good afternoon. This is Dr. Bill White, and I'm going to try to do I'm working with the American Orthodontic Society, by the way, and I want to do a group of videos that was kind of how to do things, different aspects of orthodontics I want to cover. And so today, for a few minutes, I want to go over pulpotomies and how I did them, and I've done them for about 40 some odd years and have never had any problem with a single one of them blowing up or giving any trouble. And so I want to show you how we do them, and hope you can gain from that something that will help you in doing this. Now, we use nothing but healthy deciduous teeth in this space control and guided eruption of the teeth. And you can see how we can guide these teeth in the mouth by actually slicing or reducing the teeth, sometimes in a curved manner, to let the permanent tooth come up kind of inside the deciduous teeth. And I'll try to draw that out and show it to you in the videos as we go along here. Well, okay, now I'm going to show this little girl that we did before, and on just a slicing technique. You don't just slice down in there, you have to know where the permanent tooth is, and you go around it and give it some space. And you'll see as we go through this video. It's a neat little girl. She was upset when we were doing this, but she was very happy after we got through with this. Now, excuse me, you'll see many of these cases come along, and there'll be room down in the mouth for about 3 teeth, maybe a little bit more. But if you shifted those teeth over to the center, you'd probably take this space right here to bring this tooth up. It'd just be 3 teeth in there. But we fit 3 teeth in there by guiding the eruption of these teeth and reducing these deciduous teeth. And you take one down on one side to get room for it. You do the opposite same side, and the teeth seem to center themselves out. The midline works out, and it's amazing what it will do. So just if you haven't done this, it's something that every pediatric dentist should know how to do. And really, if you're going to work on children, you really need to know how to do this too. Okay, we'll go on to a few other pictures in here and show. This is crowded on the right side. Excuse me. And the left lateral is behind. You can see the tip of it right in there. And we're going to take off enough of this tooth right here, and we'll go over and reduce this one over here. Now, if you do this, and you even take a little bit of the enamel off, and if you get it down very much, go ahead and do the pulpotomy. I never have any trouble with the teeth after I take the nerve out. If you didn't get enough, you can come back and take it down. You don't have any feeling at all in that tooth. And it has never given me any trouble. And we've done thousands of these things over a period of really over 40 years that I've written an article and published it on this case, this type of thing. Okay, here we look up above, and we've got a shortage of space up there too, so we'll come in and reduce the upper cuspids. Do the same on both sides, you know, and we let the permanent laterals come in these spaces. And watch this, how the teeth straighten themselves out. Now, if you've got a person with correct This was done before gloves and everything, so don't condemn me there. This was done back in the 70s, somewhere back there. Anyway, the lip pressure, if you have a person that's functioning correctly, you can do a lot of good in helping them come in. If they're not functioning correctly, they're breathing through the mouth or swallowing improperly and things of this type, or they're sucking on something they shouldn't be, then you need to correct function anyway, as early as you possibly can, because that's one of the big reasons for malocclusion, is function. They breathe through the mouth, their tongue doesn't go through the roof of the mouth, and so the lower arch widens out wider than the upper, drops between here. They get cross bites or unilateral cross bites, bilateral cross bites, and throws the whole thing off, you know. Okay, I didn't want to cover that here today. I want to just cover about pulpotomies. Now, you see the permanent lateral is coming in down here. I'm going to erase that so you can see it better. Now, frequently, the permanent tooth will come in and eat part of the root of the deciduous tooth away, but when it comes to the enamel, it cannot resorb the enamel, so the tooth hangs up there at that point. And if, of course, it eats so much away, it just pushes the tooth out, but that's not the situation here. This permanent lateral, which is erupting in here, has gotten caught under the edge of the enamel. The resorptive cells will eat the dentin structure up into underneath the enamel and have just a narrow part of the enamel there. So we've got to give some room for this tooth, so we'll have to go in and trim it out like that. So you can watch us do that now. Now, so this is just another view of it, and you can see the crowding we've got. We did for years with a long tapered diamond like this. We used a brand new burr, whichever. Now I use, when I was working, I'm retired now, I used 1171 long carbide burr. I use a brand new one, have it sterile, everything's clean, with a good handpiece that's clean, as sterile as you can get it. You know, put the burr in the handpiece, and then I do not use rubber dams. I will show you why, because you've got to cut into the gum tissue and go down deep with your reduction, and you just be grinding into the rubber dam all the time. And the only thing it really would be is doing the pulpotomy, and I'll show you how we do them, and I've never had any problem with them. Okay, now here we saw this tooth, it's right down here. I took a little tissue off here, but you don't really have to. Now you cut down and see where this tooth is, but don't get very close to it. And then you can come in front of it over here. Then I'll take something and put in between the tooth here and prise it open and pop this side off. Then I can see exactly where I'm going. Then I take the tooth down to where the permanent tooth can come into here. Then once we get this cleared, we'll come down with the burr and go into the pulp of the deciduous tooth. And I do all this by infiltrating. I just infiltrate the anesthetic into the gingival tissue down below here on both sides and get it numb that way. If you wanted to block the whole thing, but if you're doing several of these on the same person, it's better just to infiltrate. And when you get back on the molars, it's a little better maybe if you block the main nerves down there doing that. but I take this, I will break this part off, it'll come off, and then I can see exactly where I want to cut with the burr, and I'll ream the tooth out, something like that, and then do the pulpotomy. Okay, now we've done part of that. We take it off now. I can see this tooth, and I'm going to go around that tooth, you see, with the width of this burr or more. And then I let this tooth slide into that space, and then it can erupt up in there, and these teeth will move over, and I'm going to make space on the other side, and the thing will center out. In nearly every case, if you've got correct function, it's amazing what function does to help correct teeth. Now, where you mix this zinc oxide and eugenol is where I think most of the people make mistakes. I had a patient that, a dentist referred one to me, and I wanted him to do it, and I told him how, and showed him, gave him everything, but he didn't do it. He sent him to an oral surgeon who was an MD and an oral surgeon, but he had never done anything like this, you see, and he sent him there to do that. Well, he's supposed to know everything, so he tried to do it, but this case blew up, and it was simply because he did not know how to work with the zinc oxide and eugenol. We get chemically pure zinc oxide and just put a drop or two of eugenol in some powder, that, and we mix it up together real strong, and then we get a pad, a ball of it, something like this, and we'll lay it on paper and put something above that, and we will press it until it almost has no eugenol. We just get it, all the eugenol we can get out of it. Then I roll it into a little bit like you see here, just a thin thing, roll it out to a tip, and I get a spoon. I get just a regular spoon, and I just cut the end of that off and stick the zinc oxide on the end of the spoon, and I will show you how we do it. And it'll stick on there just like that. Now we do not want to take the blood out of the tooth. You go in there and ream it out with that burr all the way down, just as far as you want to with it, and clean it out. Don't clean it out, I'm sorry. Let it bleed. Don't try to go down in there, and certainly don't blow it out, and don't even need to aspirate it out. It's better not to aspirate. Just aspirate around here to suck any of the blood that's in there, but it's good to have the blood in here, and it has cleaned itself out. And now you're going to take this zinc oxide that's stiff enough to pack like a mountain almost. We put that down in the pulp, and then I'm going to show you on the next tooth over. We actually take an amalgam plugger and press it into that area. And I've done thousands of them, and I have never had a problem with any of them blowing up. And they don't hurt, they don't give me any trouble. But if you cut up anywhere close to that nerve, it'll give you a fit if you don't take it out. Take it out, and you won't have any problem. Now you smooth this tooth up or round it up, but you've left the root of the tooth is still down in there, and it's holding the spatial structure to keep these teeth from drifting forward in here. And this will move over. It's amazing what they'll do. And I don't have any double-blind study to show a whole stack of people doing it, but I've done this myself for over 40 years. I started this way back, and doing this is one way. I did a table clinic on this. Is one reason I ended up doing nothing but orthodontics. And I would smooth it up better than this, and that zinc oxide will just stay there until that tooth is ready to go, and you don't have to put anything else with it. I've lectured to people in many pediatric dentists up in Boston. One time I had 3 professors from 3 different schools in the pediatric department, and they all wanted to put something else in it. So it doesn't hurt if you put it in it, just as long as it doesn't mess it up. But you don't need anything. You put it in it so stiff it stops the bleeding. All right, then you come over and you trim the other side, and you do the pulpotomy over there, and we pack it in there. And in this case, I'm showing an amalgam plugger that I push it in, and then I put some more on there and kind of round it off, and then we smooth the teeth up and get them where they don't catch the tongue and the lip. And now you watch these teeth come in the mouth, and that's a fact. I just have done this so much and so long, and I do not use a rubber dam. I'm sorry, but I've never had one get infected on that, because I put that zinc oxide and euginol in there. I pack it down, and that's the place that it might get infected. And I never try to do one of these on a pulp that is infected. I've seen too many of those just go so hard. So you can aspirate this away. Now here it is a few weeks later. You see this tooth is moved in. The midline still isn't, but it has room to go over here, and this will require some more room, and this will gradually ease over as long as the person is functioning right. And now we're going to come back later and do this up above. Now, this is how you can do pulpotomies, and you'll find people that have all kind of complicated ways of doing them, but you can do pulpotomies so you're blind in the face. And if you do them this way, I've never had one to blow up. But you got to pack the stuff down in the canal and just let it bleed, and then you pack that right on top of the blood, and it pushes the blood out. It's as thick as almost like packing amalgam in there, and it'll come out just a little spike whenever it comes out or it breaks off. Now up above we're in the same problem. Now you see the bottom has come almost, this one has come up in that cut we had over there, and this is moving over, and the midline is getting closer, and it gradually moves to the midline. It's right dead center. It doesn't do it all the time on every case, but this one did. And you see the gap we got here, and that needs about that much for this to move over in that direction when we've done the upper. And so this is the first phase of the pulpotomy deal. And that midline still isn't lined up good. Now you see where this is, and you watch this, and these teeth will straighten out just from correct function. The tongue pushing on this side, and the lips catching them out here. And that's why anybody's teeth line up out there. Now this is better. It's kind of going up in this place, but it's pushing, and this has about that much to go, and that needs about that much more space, and you watch it take up that space. And I didn't touch them with any kind. This case has not had one single orthodontic thing bonded to any teeth in it. And now that's still over to the side. The upper's correct and pretty good. Now you see this is getting better. Now here we are. This is 2 of 79. And you're just watching this case, and they come in, and now the upper's straightened out pretty good. and the lower is straightened out, and the cuspid, the deciduous cuspid, has gone over here. So now we're working on the second phase of it by reducing the deciduous second molar and extracting the first molar. And that's the two phases of it. Alright, you see how the upper has lined up and the lower is lined up pretty well, but the cuspids are coming in right here. That's interfering a little bit with this tooth coming in here. So we're going to extract the first deciduous molar, and we've looked at this on a Panorex. I didn't show pictures of that, and we've got plenty of room here for the second bicuspid to erupt in here, and we take this away. That gives the first bicuspid will move back here, and this cuspid will move off into this space. And if you don't believe it, you just do this on somebody. If they're functioning correctly, their teeth will take up every bit of space in there, and you can bring a lot of people in without doing any bonded or any type of orthodontic thing at all, but they've got to be functioning correctly. I've got to stress that point for this to come out where you won't be doing anything on it. Now, let's go to another case. Okay, we take this deciduous molar out. The bicuspid is right under here, and then we're going to do this pulpotomy, where we're saving room here for the second bicuspid to come through, and we'll take this tooth down and kind of cup off down here. This tooth will come up in here, and the head of it will be right in there. It'll just slide into that space, and then this cuspid will have room to come in there. And this is guided eruption and space control, and doing and seeing what needs to be done and putting the space where it needs to be. And it's amazing what you can do with no orthodontic appliance, anything in there. If you correct the function and get them going, you can bring a lot of teeth in that wouldn't come in and need orthodontics. And you just have to try it. But I have a hard time getting people to try this. They're afraid of it for some reason or another. The pulpotomy seems to be the problem. And the pulpotomies work out fine if you just do it that way. Now I've trimmed the tooth off, and then I take a long shank, about a number 4 round burr. It's sterile and clean, and we just go in the side and go down to each horn of the tooth. You don't need anything else but pack the amount of the zinc oxide euginol into that tooth. Now I've hollowed it out. Excuse me. I've hollowed it out with that, and I cut off the zinc oxide eugenol, pack it into that tooth, and just push it in. Then I take a plugger, amalgam plugger, and push it in there hard. Put some more, smooth it off, and that's all. And just smooth the tooth up. You don't need to crown it, for God's sakes. Don't stick a damn stainless steel crown on this. Leave it alone like it is. It'll go. And that zinc oxide will be there even if it's 2 or 3 years later before the tooth comes out. And don't stick in something else in there with it. It'll stay there just solid as it can be. All right. The little girl was a little upset with us for doing this. But if I'm not mistaken, this little girl grew up, and she married and moved to another town not too far from here. And she came in with her little girl, and she wanted me to do that slicing technique on her little girl so she wouldn't have to have braces. Now, I don't tell anybody you won't have to have braces, but I can bring your teeth in many of the cases. Now, some of them are too crowded, and it won't work, but it'll work on a lot of people. And I've used it on my own son and a lot of people that you can do this on. Okay, now here she is right in the last phase of this. Now look at the center line. I have not touched this with anything other than given the space for these teeth where they needed it and came in, and the tongue pushed them up in there, and the lip structure catches them out here and lines them up. And that's where those teeth ought to be. You can do all the cephalometric studies and everything under the sun, but this is where those teeth ought to be. The pressure on the inside is equal to the pressure on the outside, and the teeth line up in that space. And I don't care what kind of diagnosis you use. It's fine to do it and learn, and you can learn a lot that way. But after you've done this orthodontics for years, you get to where you can look at somebody across the room and tell kind of what you want to do. It's amazing, you know. Now, here you see the teeth coming into those reduced spaces. We just gave them enough space to line up, and the teeth have lined up in that space. I don't know whether we don't take her all the way to the end here, but you can see what's happening. The bite is closed a little bit more than we wanted, but it's coming along. We haven't even gone into the second phase back here now. This is lined up. Now on the bottom we have gone into the second phase, and you'll see the bicuspids have, see, it came up and just slipped back. Now the crown of that is wider than the root, and it fits in here. And when this goes, there's plenty of room for the bicuspid second bite to come in, and the first molar will move forward a little bit usually and help get rid of your class 2 problem. Now this tooth of real bite is still not quite there yet, but if this moves back, this moves up into this space right here, this will have some room, and it'll probably work out there. We're making a lot of racket here. It stopped working. We'll have to take a second here and see if I got this. Alright, that's the cuspid coming down. If you have a little problem with cuspids and working in now, you'll have to have some space for that to come in. And frequently you're going to end up touching the case up after it gets in, kind of like serial extractions and things of that nature. But now this will move, this tooth will slide over in here, and this cuspid will come right around, and that's, we want to have that done this many, many times. Alright, down here, the bicuspid, you see, is come right up against that space. We've got more than we need here, so that might give us room to get this place still hasn't worked out right there. This side's worked good. We should have cut a little more off that. You could still go in there and ream that off this tooth. There's no feeling to it. You can grind that off, let this tooth drift in there a little bit more. This would come forward and this could come out, and the tongue could push this tooth out into space where it ought to be there. Well, here's a good example. Now this cuspid was about 2.5 millimeters back behind and had about this much space. And when we took this tooth moved back in and came up and then slipped back in there. And the root is narrower than the crown, and you've got plenty of room for this bicuspid to come through right there. And this cuspid, the tongue pushed it out to here, the lips catch it, and the bicuspid was pushed back into here, and you couldn't do that better. This is good orthodontics. I mean, the best orthodontics. If you can straighten the teeth by just looking at them, well, that's better than anything you can do, you know, than anything you can put on there. I don't give a darn what fancy stuff you're using. If you use your head a lot of times and do things that you know will prevent and bring the thing through where you want it, then that's better than anything you can put in there, see. And this side, you see the tooth went right back into the space we created, and it's got room enough for the other tooth to come in. This works, but I've been doing it for years, and it's hard to get people doing it. They're afraid of the pulpotomy, and that's why I wanted to go in there and show you. You don't have to be afraid of the pulpotomy. I've done thousands of them, and I've never had one blow. The only one I ever saw that blew was done by an old surgeon. That was an MD old surgeon, and probably charged him a big fee to do it, you know. But he didn't pack the stuff down in the nerve and take the nerve out properly, or it would have been fine, you know. But anyway, people need to know that, but you can do that. And here's the little girl after we finished up. She's a little happier with it now. And there she was when we started. And if I'm not mistaken, this young lady married and left the area where I was working in. I was working in Hurst, Texas, all my career. And she came back to Hurst and brought her little girl and wanted me to do this procedure on her. So I'm going to hush and hope you get something out of this, and I'll just close it up right now. And thank you for watching, and I hope you'll go ahead and do this and learn how to do it.